Hi everybody, welcome to this lecture on mindfulness-based cognitive therapy. We're going to begin with a meditation technique that is taught in MBCT called the 3-minute breathing space. So please join me, we'll practice just for 3 minutes. So first find your seat and then turn attention inwards. Eyes can be slightly open or closed. And the first prompt for the first minute is, what is my experience right now? So just noticing whatever is present for you right now. Whether it's an emotion or a bodily sensation or a thought, whatever it is. And the next question for the second minute is, where do I feel the breathing right now? Just directing our attention towards the breath or the breathing as it's happening. Maybe feeling it in the belly or in the nostrils or somewhere else. And then the third question for the third minute is, what am I feeling right now in my body at the sensation level? So just noticing whatever is present for you right now, in different parts of the body perhaps. Okay, great. So, as you're ready to, you can come out of your meditation posture and out of the meditation. And I wanted to start this talk about mindfulness-based cognitive therapy with the 3-minute breathing space because it's taught repeatedly in this approach, and as well, participants in this modality, MBCT, are encouraged to make use of this technique to really build their practice and to integrate one's practice into one's life. And I think it's a nice reminder that we can. It doesn't take too long to actually turn towards our experience, and this is just a nice way to do so. All right. So I know you all have been reading about MBCT, and just want to kind of introduce the approach. This is a group intervention originally created by 3 psychologists, Siegel, Williams, and Teasdale. And their reason for creating this was to target folks who have major depressive disorder, but who are not currently in a depressive episode. So this approach is really all about kind of maintaining, people who are doing better perhaps than they may have been in the past, and this approach is designed to help people not relapse into depressive episode. And we'll get into kind of some of the ideas about why mindfulness may be really helpful for this a little bit later in the lecture. But first, just to say also that this approach is based on John Kabat-Zinn's mindfulness-based stress reduction, which was, I believe, the first kind of use of mindfulness technique in Western medicine. Back in the 80s, I believe, is when he started MBSR at the University of Massachusetts in Worcester. And that approach targets more chronic pain. And the creators of MBCT kind of use that same model to work with depression. And so what is the model? It's one of 2-hour group sessions that are weekly. And it's a group of 10 or 12 clients or maybe a bit smaller than that, and 1 or 2 leaders who meet for 2 hours. And it's a structured modality. It is a cognitive therapy modality, but it's what we might call, or what some people call, the third wave of cognitive behavioral approaches, whereas the first wave is behavioral ways of working. Second wave would be working with thoughts and cognitions. And then the third wave is really bringing in mindfulness, bringing in, rather than having to change thoughts or trying to change thoughts, simply identifying thoughts and then noticing also everything else that might be present in that moment and not identifying with the thought. So I'll get more into that as well. But first let's look at, or let's just review the symptoms of major depressive disorder, because I think as this approach is really targeting folks with that diagnosis, just review briefly. So there's 9 criteria according to the DSM for major depressive disorder, and a patient or a client needs to have 5 of these in order to receive the diagnosis. First one is depressed mood. Second is markedly diminished interest or pleasure in most or all of the activities. The third is weight loss or poor appetite or weight gain. Fourth is insomnia or hypersomnia. So that means sleeping too much, sleeping like all day long. Fifth is psychomotor retardation, so moving very slowly. Number 6 is fatigue, loss of energy. 7 is feelings of worthlessness or excessive or inappropriate guilt. And 8 is diminished ability to think or concentrate or indecisiveness. And then the last one is recurrent thoughts of death or suicide. So again, to receive the diagnosis, a patient needs to have 5 of those. But many people might have 1 or 2 of those and might not meet criteria for the full diagnosis of major depression, but might have a depressive disorder of another sort. And I do think that MBCT would be helpful for those folks as well. And so what is MBCT all about? It's all about shifting attention to notice different aspects of what is happening right now, of the present moment. So as I was talking about second wave cognitive therapies like CBT, that's all about what's so-called cognitive restructuring, which is kind of a fancy phrase for kind of a simple process, but it can be quite helpful. And that's where you identify thoughts that may be faulty or maybe harmful to have, maybe kind of creating difficulties to have thoughts like I'm a failure or I'm a terrible person. But these are thoughts that lots of folks repeat in their minds. And in second wave CBT, you directly dispute those thoughts and try to actually replace them with more positive thoughts and thoughts that may be more evidence, based on evidence rather than just based on repeating this mantra of negativity. And where all of the approaches that we're going to study this semester differ is we're not replacing those thoughts, we're just noticing that the thought is there and it is a thought, and along with that thought there's also a bodily sensation that's present, and maybe there's sounds in the environment, maybe there's emotions present, and then there might be another thought. So really just refocusing the attention and loosening the identifying with that thought. Interestingly, in MBCT, there is actually a big behavioral component. So coming back to the first, second, and third waves of behavioral approaches, really the first using behavioral techniques, which is just behavioral activation, it's often called. And in behavioral therapy, people will often talk about two kinds of activities that are important. And this, I think, is really crucial for folks who may be really depressed. Actually getting out of the house, socializing, doing activities outside can be so profoundly helpful. But the two categories to consider are, one, mastery. So these are activities that give you a sense of, that you're good at something. And the second is pleasure. So doing activities that actually give you a sense of pleasure. And this might differ for all of us, like what these activities are. But one aspect of MBCT is actually kind of planning out day to day, and maybe even several times during the day, when can I add in something to do today that's going to give me a sense of pleasure? When can I add something in that's going to give me a sense of satisfaction or mastery? Okay, so that's one part of MBCT, is these kind of behavioral activation, kind of just making lists and talking as a group, and then kind of making a plan for what somebody might do that week. MBCT also uses, while not actually using worksheets and other things to directly dispute thoughts, which is more of a CBT technique, there are techniques in it that, like thought experiments, and we're actually going to do one at the end of the talk today, and you read about one too, and I'll go more into that a bit later. So what MBCT is all about is responding rather than habitually or automatically reacting to experience. Whether experience is positive or negative, MBCT recommends, and this is very consistent with mindfulness practice in general, just noticing what's present, and instead of just labeling and judging and reacting to an experience that may be unpleasant, just trying to turn towards it. And kind of like an open door, if you open a door, behind it there may be a number of different directions to go, maybe a number of different corridors, and that's kind of a nice metaphor for this approach. Whereas before we might have just seen a closed door, and that might mean I'm a failure or thought like that. In this approach, by turning towards our experience, we might notice that there's actually a lot of different ways to go with that. Another way to think about it is trying to cultivate a habit of describing experience rather than labeling it, judging it. Simply describing it. So at this point, I wanted to bring in a case study, and this is from an article by Kaufman and colleagues. And this is just kind of explains a client who may be appropriate for this approach. So this woman, her name is Suzanne, and she has a history of a major depressive disorder. And it's the holiday season. She's entering into this holiday season. And she's actually noticed that she stopped a lot of her self-care activities, including her meditation practice. She stopped socializing as much as she had been, and she stopped exercising. And her mood tends to be getting more irritable, more upset, more negative self-talk. For example, criticizing herself for not doing more each day, criticizing herself for not exercising, saying, I'm a failure, I'm a mess. She has less energy, she's more fatigued, and this leads to even more negative thoughts like, I'm not good enough. And then this, for Suzanne, escalated into a full-blown episode of major depressive disorder in which she wasn't getting out of bed and had other difficulties associated with that relapse into that episode. And so MBCT is all about, if somebody is like Suzanne, it's how do we intervene in ways to prevent that relapse. One way to think of this comes from the Padula reading, where Padula talks about how depression is a way, actually, of turning away from pain. But in so doing, one is turning away from life. So for Suzanne, presumably she was feeling unpleasant sensations and unpleasant emotions, and the response to that, the habitual response, is to turn away by not getting out of bed, not engaging in her exercise and socialization, etc. And mindfulness is a wonderful way to help folks or invite folks to turn back towards what's present. And I want to say a few points just about the underlying theory of MBCT, because I think it's quite useful. And that is that a person who is in a depressive episode has made a habitual association between painful emotions and bodily sensations and negative self-critical thoughts. So this is the main idea in MBCT, is that these so-called autopilot associations of negative inner experience, negative mood, negative sensations, negative emotions, this autopilot association of those experiences with habitual negative thoughts kind of creates a bridge, we could say, that has been built and buttressed over perhaps years by repeated negative thinking. And this can lead to more negative experience at the emotional sensation level, which then can lead to more negative thoughts, etc. And it just can get worse and worse. And it's kind of a self-perpetuating cycle that continues to kind of grow this negative experience. And actually, we know now with kind of where neuroscience is at, that the brain develops synapses based on how the brain is used. So if you keep saying I'm a failure and having negative emotion, it's very likely that you're going to just continue having more of those negative thoughts and more of those negative feelings. So MBCT postulates that what we want to do is help clients slow this process down. And just by things like this 3-minute exercise, this breathing space, is to uncouple the negative thoughts, emotions, and sensations so that the clients can make more skillful choices about how to respond to unpleasant experience, and not engage this whole cascade, or what in the literature is sometimes called the downward spiral of mood, of this automatic linking of negative emotion, sensation, and thinking. And MBCT also targets rumination itself. This cascade of negative experience tends to be perpetuated by our tendency to ruminate or to habitually, repeatedly think about a worry or a problem, trying to mentally kind of undo the problem. You may remember the concept of Shenpa from your class last semester, so I think that fits in nicely here. This is trying to mentally resolve this discrepancy between what you want and what actually is. And so with mindfulness techniques, we can kind of slow that process down and just notice what's actually present, even if it is unpleasant. So we can think of this as being in the being mode rather than the doing mode. So being means just observing non-judgmentally what's present, whereas doing, this is in this case a mental doing, repetitively ruminating on a negative thought. That's actually a way of doing. And so just slowing things down, turning towards your thought or your body sensations is what we're talking about. And another idea here that may be helpful is to think of quicksand. I don't know if anyone who's listening has been in quicksand, but in quicksand, what one is supposed to do, I guess, is to not move. That way you don't sink further. If you move, you try to escape you tend to just make things worse for yourself, and you get buried in the quicksand. And similarly, that's what we're talking about here. It's just slowing things down, not responding as we have in the past, and just being with what is. It gives us capacity to actually respond rather than that same old reacting that we've been doing. And another way to think of it is like decentering the thought. The thought may have been the thing that is present above all else in one's attention. And through these practices of just shifting attention to sensation, to breathing, to sounds in the environment, etc., we might notice that, I also am having a thought, and it's a judgmental thought, it's a negative thought. Okay. And I can then come back to what's also present right now. Another important point about MBCT is that because it's a group approach, there's just some aspects to group therapy that are so helpful for someone who's really struggling with depression. First is just being in a social situation. This, many folks who struggle with depression also tend to isolate. And so just being in a social situation with some regularity over several weeks might actually be a big part of what helps people get better. Additionally, stigma and self-stigma is another big hallmark of depression for many folks. So these are kind of thoughts that not only am I struggling with depression, but now I'm struggling with the thought that I'm broken or I'm worthless because I have depression. And there's just one aspect of being in a group is that what Irv Yalom, the famous group therapy practitioner, he calls it universality. So this is just learning from the experience of being with others that may have similar or may have different kind of symptoms or reasons for being in the group, but just learning that one is not alone, that one can probably relate to everybody else in the group in certain ways, and so it can really help with that stigma and that negative self-talk. And then lastly, one of the great things about group modality is seeing all the different possible responses to a situation. And in the exercise that we'll do in a few minutes, we'll see an example of that. And actually, we're going to do it right now. This is called the thoughts and feelings exercise. This is I took this from the Bear article. But let's try it right now. So I want you to just imagine that you're walking down the street and you see somebody that you know walking towards you. And you wave to them. This person perhaps doesn't notice you, and they walk by. They seem to not notice you, and they walk by. And you might just take a moment now and notice what you're associating to. Maybe you're imagining that that person was upset with you and intentionally ignored you. Or maybe you have another thought. Maybe they just didn't see you. Maybe they didn't put their glasses on. In MBCT groups, one activity in the group is to actually kind of one of the leaders will do what I just did and talk through this prompt, and then the clients think for a moment and maybe write a few sentences about their response, and then they have the clients read out one by one how they interpreted the event. And what can be available here is just seeing that maybe some person got really angry, another person got really hurt, somebody else was actually concerned for the person who they saw on the street. So a very different emotional response. Maybe another person was embarrassed, and maybe a last person had a totally neutral response. So this exercise and others like it highlight how each of us really has a filter through which we interpret reality and can help us de-identify or de-center our own interpretation. Or another way of saying that is just not seeing our thoughts as actually facts, as not explanatory, but rather just thoughts that may or may not be correct. So again, this is one of the activities that rather than doing thought challenging worksheets and things like that. This is how MBCT employs kind of the cognitive aspect that it does by kind of these thought experiments that are done in the group. So, I guess that's all I wanted to say about MBCT. For now, certainly we can talk about it some more in a live video call or at other times. But I did want to close with just saying a few things about how to start to use mindfulness techniques in your sessions, and especially for those who are doing the version of the final with the practice sessions. I'm using some of the recommendations from Polak's chapter in the text. One thing she brings in, which I think is quite useful, is the idea of creative hopelessness. And we'll talk a lot more about this when we get to our module on acceptance and commitment therapy, because that's where this idea comes from. But just to say here that creative hopelessness is an idea that the moment of pain or of anguish that a client is struggling with is actually, and we can see it as a real opportunity, and how this moment of difficulty actually sets the stage to consider something different and consider acting to do something different. So that's one idea just to bring in. The next is when we're leading a client in a mindfulness exercise, just some important points that she made that I think are useful. One is that you can say this approach is grounded in research, and there's a lot of evidence that we know this is very effective for folks who are struggling with depression. And for example, we know that mindfulness-based cognitive therapy has been through several randomized controlled trials. That's like the gold standard of research for therapy modalities, and we know that it's effective for majority of people in those. So just saying things like this can be helpful for folks who may be a bit skeptical of Buddhist practice. And additionally, you might even not say the word Buddhist. You might say, let's do some working with our attention, some attention training, or let's try an experiment. Let's see what happens if we try this 3-minute breathing space. And then she also used some language which I really appreciated, which was the therapist saying, I will do this with you, and we can stop at any time. So just emphasizing that, it's not for the client to do alone, that it's going to be something done by the therapist too, so it's participatory, and also empowering the client to stop the process if it's not working for them. In the Padula chapter, he introduces some ideas that are helpful, or may be helpful. This is one of the ideas is to focus on body sensations, and especially sensations at the periphery of the body. For example, the feeling of the cushion under the legs, or awareness of sounds in the environment. These can be more accessible. One way to think of this is going from outside to inside. So, if someone's struggling, maybe don't have them focus on what's happening inside their body, but more, on their skin, or the feeling of the clothes, or the air on their skin, or maybe even the extremities. That can be super helpful, like noticing what's happening in your palms, in your fingertips, the soles of your feet. This can be more accessible for folks, and so helpful to just consider that. And also another recommendation from Padula is to emphasize touchstones or anchors. These are places in which there may be more pleasant sensations in the body and less unpleasant sensations. Or another way to think of that is where the breath energy is just flowing more easily. So if there's pain or something like that in one part of the body, we can invite a client to notice that, and also come back to or maybe the breath as experienced in the breathing in the nostrils and the throat may be more of a flow. And so this may remind you of touch and go, which I think you all learned in the psychology of meditation. So touching into a difficult experience and coming back to pleasant experience, and then titrating like that. Just a couple more points. Thinking about contraindications. So, and we can talk more about this, but Pollack mentioned how sitting meditation may actually be contraindicated for somebody with, for example, depression, because it's a disorder of, amotivation or lack of activity, lack of motivation. And so it may be more indicated there to try something like walking meditation, where there's movement, or a yoga practice where there's a movement. Similarly, somebody who has severe PTSD may not be the best candidate for really focusing on internal feelings and thoughts, because we know it's one of the hallmarks of PTSD to have intrusive thoughts, flashbacks, etc., and can be quite difficult for someone struggling with that to turn inward. And so in that case, there's some recommendations to consider working with sound, working with walking meditation, or other techniques. And I'm going to put another article that wasn't in our assigned readings, but it's a short one. It's another one by Pollack, where she goes into, I think it's 7 myths about mindfulness and 7 kind of antidotes to those myths. And I think it's quite helpful as we're considering contraindications and how to tailor mindfulness instruction so it actually works for the people who are sitting with us. And then finally, just wanted to invite us to think about how might we unpack or debrief a mindfulness exercise that we're doing in session. And as you're doing your practice sessions, you might think about how you're going to do this, in addition to thinking about how you're going to introduce mindfulness, which we talked about earlier. But just maybe you could ask, as you're leading the client out of a mindfulness exercise, a simple question: what happened? Or what did you notice? Or did your experience change, or did it stay the same? And one idea here is that I was taught at some point is to not ask a question like, how was your practice? Because just the phrasing of that actually invites judgment. So rather than inviting the client to judge their practice, we just want to invite them to share observations. And just want to bring in a last point here about MBCT. One big hallmark of this approach is the group leaders actually modeling this non-judgmental awareness. And so in the way that they interact with the group members is they're constantly trying to just accept what the group members bring in and help notice by modeling, help the group members kind of develop that capacity to just notice and not judge and just invite. And it's this non-reactive, non-judgmental awareness. So I'm going to stop here. Hope you are engaging with this material, and please do get in touch with me if you want to speak about this. We can set up a meeting. All right. Take care, everybody.